Okay, welcome back to part 2 of Unit 6. So we're going to continue with glaucoma treatments for the eyes. So the next section we're talking about are prostaglandin analog drops. So these are pretty common. They're the TANs, Xalatan, Travatan drops. And these work by increasing absorption of that aqueous humor so that we can bring down that intraocular pressure. The side effects with this one are generally localized. I've given lots and lots and lots of these drops, and that's because usually if it's going to affect anything, it's just going to affect the eyes. So changes in eyelashes, eye color, localized irritation and itchiness may be side effects, so you don't have those systemic side effects like the other ones. Okay, another one is carbonic anhydrase inhibitors. Diamox is another type. These decrease production of intraocular fluid. They're available in drops or a PO form if the drops are ineffective. There may be tingling or loss of sensation with hands or feet, nausea and vomiting, mental fuzziness, memory impairment, depression, higher risk for kidney stone development, and cause urinary frequency. And then there's also the localized eye discomfort. So that one comes with a lot of systemic problems that may happen with that medication. I've seen Diamox given a few times, but definitely that Xalatan, I've given lots of that one. Osmotic diuretics can also be used. Mannitol is that one. It's an osmotic, right? We talked about that one with like brain swelling. So this works by pulling fluid from the eye and putting it into circulation. And something to watch out for would be those intracranial pressure changes. So it can almost make the brain too dehydrated if they're used too much. Okay, then we got a couple of surgical things. The iridotomy, this is where a surgical laser incision is made through the cornea to remove a portion of the iris to facilitate aqueous humor drainage. This is for closed angle glaucoma. And then the trabeculoplasty, this is a laser that is used to create multiple scars around the trabecular, the fibrous cord-like connective tissue meshwork where the fluid needs to drain into. This allows for increased outflow of aqueous humor, therefore reducing the intraocular pressure. And then this one is for open angle. And then I've got my little cartoon there, the 3 P's of blindness due to open angle glaucoma. It's preventable. I should have seen this coming, painless, and then permanent with that open angle, because that one's the more insidious one. Here's another picture for glaucoma risk factors. It's familiar, meaning it's genetic, over the age of 40, diabetes and hypertension, and then history of ocular problems. So, okay. Retinal detachment. So retinal detachment, this occurs when the retina is pulled from its normal position. There's a little picture of it here to kind of see what's going on with that. Can occur spontaneously or from trauma or maybe some other co-condition like diabetes, hypertension, things like that. Can be caused by diabetic retinopathy and may also be caused by high blood sugar levels that damage blood vessels in the eye. Assessment. So people tend to see that they see floaters in their eyes, may have flashes of light even with their eyes closed. See cobweb. Another one that I don't have written down here is some people will say like, it looks like there's a curtain covering part of their vision in one eye. That is sometimes an assessment finding. So if anybody is having those assessment, like if you're hearing from a patient that's saying, that they've got these kind of assessment things happening, they do need to get into an eye doctor sooner than later, because sometimes permanent damage can be caused because of that retina coming down, especially if it's, hopefully you can see my mouse here, if it keeps going. Okay. Sorry about that interruption. So if this retina becomes detached too far down and starts to get in front of the optic nerve here where it's going to peel off past that point, then blindness becoming permanent or having like very profound visual changes is going to be more prevalent, I guess, with that. So we want to get them help as soon as possible. My uncle, I've talked about him before. He's the one that his appendix ruptured when he was out on the combine. He's a tough guy. He doesn't go to the doctor unless he feels like he's dying kind of thing. So anyway, he actually had a retina detachment over the summer while in the field and stuff. And didn't go to an eye doctor for 6 weeks. He kind of had where it was that curtain coming down in front of his vision, and didn't say anything to anybody about it. Just went to his eye doctor one day, and they're like, you have to go to Omaha like right now because it was so close to this optic nerve area. And then they had to attach it, and then, it's at risk for it doing it again. So diagnostics, it can be diagnosed with a simple ophthalmoscope procedure. I've got, another picture here. Those are the little floaters that people can kind of see. And then here's a picture of that retina falling down. Here's a picture of what we would see with that ophthalmoscope, that you can see the retina is like falling down, right? That red and orangey area is, it's being partially covered. It's obstructed. Treatment, using a laser to reattach the retina, cryosurgery, pneumatic retinopexy, and then scleral buckling. That is used to secure the retina back in place. Okay, we're going to continue with retinal or diabetic retinopathy. This is a condition caused from high blood sugar levels damaging blood vessels in the retina. It causes new ones to form that keep kind of getting congested, that causes eventual blindness or a detached retina. So here's normal vision. Here's somebody with diabetic retinopathy, what they see. Here's a normal retina with ophthalmoscope. Here's one with diabetic retinopathy, and you can see where those blood vessels continue to form. They're bleeding, they're hemorrhaging, and that's covering the retina. So it starts impacting their vision. Assessment, they'll have decreased visual acuity. So I got this note here. I've had patients that because, we diagnose them with diabetes, they start getting on a treatment, they're very compliant with it. And then I get a call that says, so I just spent a whole bunch of money on new glasses and now my eyes are better. And that's because if we can assist with diabetes treatment as soon as possible, get people to be compliant with it, their vision is going to get better. Those blood vessels are going to stop rupturing. They're going to stop getting that damage from the high blood sugars. They're going to start healing. And then we can actually prevent that damage from occurring further. There are some studies out there that are very interesting, especially your community-based healthcare system. So, like the Siouxland community healthcare area. This isn't something they necessarily do. I'm not even sure if they do this or not, but that's an example of these places when what they're doing is if they have a client that has diabetes, they usually will start because of, cost and everything with a long-acting insulin. And they'll actually have the patient come in every day to get their injection at these health places. And then after 2 weeks of doing that, they'll actually test their visual acuity again. They do an initial one before treatment, and then they'll do one after 2 weeks, and they'll see it's better. And then it helps with compliance, that when these people, start doing their own treatments at home, they're more compliant with it because they can actually see, yep, it did change. It got better. Diagnostics, diabetics must be screened for this yearly by an eye doctor. Sorry guys, I'm trying to work next door to my son here with his computer. So he's trying to do his schoolwork and I'm trying to do my work. So anyway, oh shoot. Okay. So treatment for diabetic retinopathy, they can do what they call laser photocoagulation and or virectomy. So they try to minimize those blood vessels that are forming. And then the other part is just controlling the blood sugars and making sure that people are staying compliant with their treatments and, early diagnostics really too for diabetes. All right, the next one is macular degeneration. So macular degeneration, this is a disorder of the eye in which there is a deterioration of the macula. So the macula, without this is going to cause blurred and distorted central visual activity. There's two types of macular degeneration. There's the dry form and the wet form. The dry form is way more common. It's like only 10% of the cases are the wet form. For dry form, photoreceptors stop functioning due to age. The photoreceptors are unable to be replaced anymore. The wet form is when blood or vitreous fluid collects and new blood vessels form, which limits the vision. So my grandma, she actually has macular degeneration pretty bad. It's been progressing for years and years and years. She actually has the very rare wet form. She has to get injections into her eye like all the time. It's because she has little bleeders that are forming all the time. So this one starts stealing the central vision, and then you have to rely on your peripheral quite a bit. So, to kind of empathize with this person is going on, you just look straight ahead, but then try to just use your peripheral vision in order to even like read. So look at something then and try to read off to the side. It's very, very, very difficult. So my grandma, I know she struggles with this quite a bit. So tests and screenings that we do, you've probably seen this before, this type of a grid. So what they want you to do is they want you to look at that center dot and see what you see. Usually you're supposed to see all these grids, all these boxes, and then a black dot in the middle, right? Somebody with macular degeneration is going to have this kind of wave-like hole pattern. Like the lines aren't going to be straight. They're going to be curved. It looks like it's sinking in. I believe that's called an Amsler grid. Oh, there. Yep, I have it written there. Amsler grid. And then you check it one eye at a time and then every day. So my grandma had this on her fridge and every day she looked to see like how it was progressing, and then she kind of knew like when she would have to go to the doctor. So there is no cure for this. We have treatments that slow it down, but it's not going to stop it. So we check visual acuities, both distance and near. The macula is visualized with the ophthalmoscope and the pupil dilated. They can do fluorescein angiography, which is IV injection of dye into the blood flow. It shows those leakages or obstructions in the bloodstream. And then, like I said, that Amsler grid. So treatments, let's see. Oh, I guess I don't have that there. Treatments is going to be eye drops and some other types of things in order to help slow that progression, but it's not going to prevent it. It's going to keep going. We're going to go into blindness next. Blindness, this is where vision is severely limited. Visual acuity that is not able to be corrected. Like the visual impact is so severe that there's no amount of glasses or contact lenses or anything like that that's going to help. These people are considered legally blind. This is where best visual acuity with corrective lenses is 20/200. Meaning, if a person is standing 20 feet from that chart, a person with normal vision can stand 200 feet away from that chart and still see it and still be able to read that letter. Consequences, blindness in one eye affects field of vision and causes depth perception issues. We talk about safety issues, taking correct medications, crossing the road, shopping for groceries, and then maybe even getting lost. Nursing care, promote independence as much as possible, involve family, and verbally describe environments and activities if it is a person that is legally blind in both eyes. So I'm going to stop there with this recording, and we'll pick up with hearing in the next one.